Okay, hi, my name is Shandini. This is my partner Victoria.
Hi.
We decided to discuss the impact of perinatal death on OB nurses. So, two studies were conducted on OB nurses, and I'm going to start off by discussing study one. So, the population in study one was, of course, the OB nurses, specifically at the Zervarsky Medical Center. So, in this study, there were two waves that were conducted. A month after the first wave, two consecutive incidents of perinatal deaths have occurred, and one of them was involved with OB nurses. All of the OB nurses filled out questionnaires assessing mental health conditions to get the whole study started, and each OB nurse was interviewed for their background characteristics, and also there were demographic variables that were also coded. So the psychiatric symptoms in the study, they were assessed by three measures. So the PTSD symptoms were assessed by the impact of events scale, and depression symptoms were assessed by the Center of Epidemiologic Studies depression scale, and the psychosomatic symptoms were measured by the psychosomatic problem scale. Regarding the statistical analysis of this study, a set of hierarchical multiple regressions were conducted. And so where the independent variables were the demographic variables in step 1 and life satisfaction in step 2. All of this was done in order to see whether life satisfaction is associated with the level of psychiatric symptoms, which were the dependent variables. And that whole set was replicated twice. So all in all, study 1 was where OB nurses were measured longitudinally at the baseline, and they were also measured 3 months after. The results of study 1 showed that OB nurses showed a higher level of psychiatric symptoms at time 2 compared to time 1. So time 2 was wave 2 and time 1 was wave 1. And just in my opinion, I think that both of the studies, not just study 1, but study 2 too, made it a really good point to just explain the exposures to perinatal death and how it affects all the OB nurses.
Okay. And I focused on study 2, and the participants of study 2 were gathered, and they were participants from the first study that Shandini just talked about, and they were also OB nurses who were not exposed to perinatal death in the past 2 months. The premise of this article was exposure to perinatal death in OB nurses leads to a higher level of psychiatric symptoms such as PTSD, depression, and psychosomatic symptoms. The supporting points for Article 2 were there were 3 tests done. One was the T-test, another one was called a Mankova test, and the third one was a hierarchical regressions test. All 3 yielded basically the same results. They found that nurses exposed to perinatal death had a higher level of symptoms of PTSD, depression, and psychosomatic symptoms when compared to nurses who were not exposed to perinatal death. The significance of these premises to nursing and end-of-life care are, I will talk about. First is preparing the family for death. It is very important to prepare these families who are going to lose a child, especially a newborn child, and just let them know what's going to happen during the process. Maybe get them involved talking about how they're going to deal with this, how they're feeling, educating the family on the death and dying process, letting them know what to expect, what's going to be going on biologically, physically, mentally as the child is dying, and also getting them in touch with resources for grieving, perhaps a parental support group made up of parents who have lost children. Pain management is a big thing. As we've learned in nursing school, there have been scales to assess pain. One is the FACES scale, which is very useful when you have an individual who can't outright state that they're in pain or what their level of pain is. Hospitive and palliative nurses are also very good at recognizing signs and symptoms of pain in patients who cannot verbally express their pain level. Non-pharmacological methods of pain also will play a role, such as using therapeutic touch, encouraging these parents of these babies, if they're not already deceased when they come out, to hold their child. Oftentimes parents will try to distance themselves once they find out that their child perhaps has a terminal illness or won't make it very long, to save themselves the pain of perhaps losing a child. But I do feel like it is very helpful to have that therapeutic touch and parents engaging with their child, and it might help the grieving process as well. Advocating for the patient, since these patients can't speak for themselves in this particular case, educating the family on the realities of their condition and the realities of medically prolonging life can sometimes be useful in helping them make a decision to let the child go, or perhaps ease some of the feelings of guilt that they'll have over the death, because it'll feel like they're giving the child a less painful death, perhaps. I recently had a palliative care nurse. She also worked in hospice care come in and speak to my clinical group, and she mentioned that this was one of the main problems that she's seen in her line of work is patients, the patient's family not wanting to let go or wanting to continue courses of treatment that will prolong life, but often they just cause more suffering in the end because they will die no matter what. So that is very important to just educate them on certain life-saving measures, even CPR. If a dying patient if their family doesn't want them to still go off or become DNR, they're going to want them to do resuscitation measures. Well, that can involve breaking ribs, which can just make their suffering worse. How this relates to the course content this semester, this article relates a lot. I found that there were ethical considerations that we're going to be talking about in this class, and one of which is the concept of autonomy. It is very important to respect the patient's wishes as a nurse, and or the family's wishes if they have power of attorney or are able to make decisions for the patient. The patient has allowed that on their behalf. The nurse must respect that at all times, even if it isn't what the nurse believes herself or himself, their spiritual or religious beliefs. Also the concept of non-maleficence, providing symptom relief, even if it hastens death, is another thing. Most of these drugs that will be given to patients do have the side effect of they will probably accelerate death in patients who are already dying. And also we're talking about self-care for nurses too. Well, I think that self-care involves support systems for nurses, such as their co-workers or turning to spiritual or religious support, both for the nurse and the patient. Also withdrawing or withholding care, as I've mentioned before, life-sustaining medical interventions or treatments at a certain point in an individual's disease process begin only to prolong suffering. That's another thing that the palliative care nurse mentioned. She said at a certain point it's having that conversation with the patient that this prolonging life will perhaps only be prolong your suffering. My opinion on this matter of this article is because the death of a perinatal patient affects not only the family of the patient but the caregivers, i.e. the nurse, it is important that nurses are adequately trained in how to cope with death and dying in perinatal patients. It is important that nurses have support systems in place to help lessen the possibility of them developing some of these symptoms such as PTSD, depression, and the psychosomatic symptoms that we've mentioned that come along with witnessing the death of a perinatal patient or any patient. This article yielded results which found that nurses with adequate support systems both in and out of the hospital had less incidences and reports of symptoms of PTSD, depression, and psychosocial issues. Another interesting thing in the article that I found was they found that being married was considered a protective factor against a high level of PTSD symptoms in nurses. So they have that support system at home, which is good. I also believe it's the duty of healthcare organizations to provide their healthcare staff with adequate resources, such as support groups, to help lessen the possibility of symptoms of PTSD and depression developing in their staff. Getting them talking, as we've learned, therapeutic communication can really be therapeutic, not only for patients, but for nurses and other healthcare workers. And also the article mentioned short-term changes, such as extra days off after the death of a patient for nurses may help to prevent the development of compassion fatigue and stress in nurses, which is a big issue that we learn about in nursing school, which I also believe can be helpful. Getting maybe daily or weekly thing together where nurses and other healthcare workers let the staff talk through their issues if they had a really hard time the previous week would be helpful, to just see that they have their co-workers and other people supporting them and in the same situation. And as I said, the supporting point would be the people who have their families at home supporting them. The being married is a protective factor. And as we all know, death takes a toll on any nurse. And in this study, it discussed the toll it takes on OB nurses and their mental condition. And exposure to death, they found, can lead to an elevation in psychiatric symptoms. Overall, I feel it's very important. Palliative care and hospice care nurses, one of the things that they do is help, not only they help patients talk through, they give them a realistic view of what palliative and hospice care is. One of the things that speaker also mentioned, the nurse, was that one of the biggest issues she found that patients had were their misconceptions about hospice and palliative care, and also the family's misconceptions too. They believed many times when she was talking to them that palliative care or hospice care, going into that, was an acceptance of death, that their family or perhaps even themselves, they were giving up on themselves, and that was one of the main fears with that. As usual, education and even helping nurses will really help improve, lessen these symptoms of PTSD, depression, and all that in nurses. And to conclude, I'll turn it over to my partner. Thank you.
And so to just go off what Victoria was saying in the last part of her discussion, perinatal death obviously has a traumatic experience for both the mothers and the parents. And so even though these two studies were conducted on this specific matter, to this date, there is no study that was conducted on OB nurses, psychiatric and psychological reactions to perinatal death. And that's all we have.
Thank you.